Hi, everyone. You're here today with myself, Anna Walton. I'm a registered osteopath in Canberra and part of the Osteo Kids Academy. Our guest today is Natalie Moore, who's the practice principal at Moore Pathways in Brisbane, Australia. Natalie is a registered osteopath with a research master's degree in dysfunctional breathing. She works with infants and children, addressing concerns such as breastfeeding difficulties, reflux, colic, gastrointestinal issues, respiratory challenges, and developmental milestones. I'm very much looking forward to seeing Natalie present this year at the Australian Society of Tethered Oral Ties Symposium in May on the topic of the osteopathic guided frenectomy. So we'll go through that today as well. Welcome, Natalie. So good to meet you.
Thank you. You too.
Um, yeah. How did you find your way into osteopathy?
So I started off as a remedial massage therapist, and I got very heavily into myofascial release, and I started working with physios, and I was always in physio clinics. And I actually got into study physiotherapy, and I thought I was going to be just this kind of bring this new form of therapy through. And I was speaking to the physios, and I'm like, I want to do physio, but I'm going to do it like this. And it was actually the physios that were like, well, that's actually just osteopathy. You might as well go do that. And it turns out that this whole paradigm actually already exists. And I was living in Sydney at that point, and I moved to Byron Bay. And it was a housemate that I was living with, and they were like, "Oh, I'm studying osteopathy," and I hadn't even seen an osteopath. I didn't really know what they were about, but I enrolled and got in and started my osteopathic journey. And I remember the first osteopathic lecture that I sat in, and I remember thinking, "Oh, this is everything I've been looking for. This is it." And so that's how it started for me.
Wow. So instead of you sort of being introduced to
Mhm.
osteopathic principles, you kind of had them all along and found the profession that worked for your own
Yeah,
sort of thinking around
I
health
think
and
in a way,
healthcare.
yeah,
What are the chances that
I
your
think so.
flatmate
And
was
I
an
think I was
osteo?
really lucky because I went to a really well, kind of high in Byron,
Oh,
actually.
okay.
There was
Fair
quite a
enough.
few osteopaths around going to the SCU college in Byron. So, but yeah, also very serendipitous to move in with someone who was studying that. So it did seem like everything was just and it's the same with the breathing work I do. It all just sort of like it's all just put in front of me, and I just keep just stepping on the next stone that's in front of me, really.
Mm. Oh, how wonderful. Um,
Hmm.
Speaking of breathing, so you have a research master's on breathing dysfunction. Tell us a bit about that.
Well, that was the master's in osteopathic medicine, and it just so happened. I can't really remember how it went with our school, but I think it was the first year that they decided to allocate the research topics. Um, and again, serendipitously, and it was just amazing that Dr. Rizalba Courtney just happened to be one of the supervisors and wanting to do one of the subjects. And I just happened to be in the group I can't remember if I chose to be in that group, which I would have chosen anyway, or if I was put in that group, I can't remember. But it just so happened that that's how it worked out, and it was perfect.
Wow. And what was your topic?
Yeah. We were validating the manual assessment of respiratory motion. So throughout the masters, we had to kind of read all the research and do the lit reviews and really dive deep into dysfunctional breathing patterns and all of Dr. Rizalba's research prior to that. And then our actual research was on validating the MARM. And I don't think our group, I think we collected all the data and we did it all, but we didn't get it quite finalized. And I believe that the year after us got it published.
Validating the MARM. Is that a breathing assessment?
So that's the manual assessment of respiratory motion. So it's
Right.
something that Rosalba uses in her breathing dysfunction assessment. So, and it's something that any practitioner can use.
Gotcha. Right. Yes, a couple of the osteos I know from Canberra did Rosalba's 6-month training and
Yeah,
just raved about it. And I
yeah.
gather it's very, very useful in peds to have that skill set.
Yeah, I did that one as well. I wouldn't say it's really a pediatric. It's not, it's, I think, probably helpful for kids in a way.
Hmm.
I, the, not so helpful for babies. But if you're wanting to do any sort of breathing work or really understand breathing in a deep way, more than just the diaphragm, then definitely you would be doing Rosalba's integrative breathing therapy accreditation for sure.
Gotcha. Yeah.
Yeah.
Um, so now you work with dentists, is that right? Tell me more about that.
So I work with dentists amongst like all the other different practitioners that I work with, but I guess I have a reputation for working with dentists because I do the guided frenectomy. Um, but in terms of the things that a dentist, or I guess other dentists in Brisbane as well, refer to me a lot for TMD, chronic headaches, tongue tie stuff. Um, they kind of, I think dentists don't know too much about the body more than just here. So I think when they're working on maybe the palate or the jaw or whatever they're working on, I think they get a hunch that maybe there's something a little bit more to it, or maybe this patient needs a little bit more hands-on treatment to support the treatment that they're getting, whether that's orthodontic work or sleep work or um, however that is. So it's really quite broad. I think the dentists have an idea of what they're sending to me for, but it actually might be completely different. So I might be working with a patient who has pain or headaches, and you're just going to do the osteopathic thing and look at the whole body and determine what that primary sort of thing is. And the primary thing might be a breathing dysfunction, um,
Hmm.
or it might be stability problem, or it might be an ascending driver, who knows? So really, I think I just have a reputation amongst the dentists. And I say this to so many osteopaths, like, what they ask, what specifically do I do? But the specific work I do is just being an osteopath, and it's just pure osteopathic work at the end of the day. It's nothing different.
Gotcha.
Mm.
Oh, interesting. You're so right. We often see people who've had dental work or orthodontic work and end up with a whole lot of neck and jaw pain, and it doesn't seem to be something that a lot of dentists would ever consider, having some sort of team care for.
No, but I think as osteopaths and any allied health professionals, um, it's probably up to us to approach them. I think there's certain dentists within the field now going to different courses and symposiums and things and seeing how well osteopathy works within that paradigm. And they kind of reach out a little bit more now. Um, but if you just it's the same as building a referral relationship with any field. Like I have referral relationships with gynecologists and naturopaths and GPs. It's just the same thing. It's just about, I think it's about as well learning the language of of that field. So I know a lot of the language in the myofunctional and dental sort of field. So I know how to talk to them and I know what language they use. So that's kind of part of the research as well and part of working with whatever field you're going to work in. But when I see a patient in my room, I'm just being an osteopath. But I think with the networking stuff, it's just speaking the language of that realm, really.
That makes a lot of sense.
Hmm.
Um, how did you end up treating babies with tongue ties?
Um, so that's like a completely different, it's almost like I run these like parallel lives as an osteopath because I work in so many different fields, but they all are the same thing. It's just being an osteopath. I started working with babies as a new grad. I moved to Brisbane and started working with Shani McCook, and she had a little clinic in New Farm, and she was just treating babies. And at that time, I was really into women's health. So I was doing a lot of CPD in women's health. And Shani ended up getting pregnant, and I don't think we could really find another osteopath that was able to come on board to take over her pediatric list. And I spent a year being mentored by her, sitting in on all her consultations, and she was a lactation consultant as well. So I got thrown in the deep end and took over her pediatric list. And I think the first week I started treating babies, I had like 30 babies, and I was so overwhelmed. So, but it was so good. And that really set me up for treating pediatrics. She was mentored by Maxwell Fravel. So that it was that sort of treatment, and also being a lactation consultant, learned a lot about tongue ties and breastfeeding as well. So just from that, I just started treating babies, and that was it. I haven't stopped. And I love it. It's probably my
Yeah,
favorite part of being an osteopath.
it is pretty awesome.
Yeah.
Tell me more about what you find in babies with tongue ties. Obviously, those of us that treat babies with tongue tie often notice similar patterns and things that we find in those babies. Tell us what you find and what you commonly treat in your sort of osteopathic assessment and whole body treatment of them.
I feel like specific with tongue ties.
Yeah.
I'm really aware that there's probably going to be osteopaths watching or listening to this. And so I feel like I don't want to say the wrong thing. It's probably, from my perspective and the babies that I see with tongue tie, I would
Mm.
say that it's very rare that I would diagnose a tongue tie on the first session that I see them.
Okay.
Um, I might acknowledge that there could be a really obvious tongue tie there. But unless it's a very obvious anterior tongue tie, it would be unusual that I just kind of jump in and go, there's a tongue tie there, let's go get it released.
Mhm.
And then I look at all the other patterns in the body. I see, just again, just very pure osteopathic things. How is the jaw working? How is the cranial system working? How are the diaphragms working? How's the first breath feeling? How is the nervous system? What are the hips doing? All that sort of stuff.
Yep.
The anterior fascia is really important. Where the jaw sitting is really important. What the cranial base is doing is really important. Obviously, all those things. I
Mhm.
work closely with a few LCs in Brisbane, and they're all really good. But the more difficult cases, I work closely with the lactation consultant. Her name's Bridget Ingle, and she runs quite a few courses. So on the more complex cases, the less obvious tongue tie is the ones that there might be a presentation that to, a lactation consultant or to a pediatrician or who are into tongue ties might say this is a tongue tie. We've actually found that tongue ties can really change, or the lingual frenum can really change with treatment because of the fascial connections. And sometimes when there's a little bit like we're on the fence, like the tongue is obviously restricted, it's not doing, the motions that we need it to do, it's not cupping, it's not lifting or whatever it might be. After maybe one or two treatments, the tongue fascia sometimes just really either lifts up, and then all of a sudden this like really obvious tongue tie pops forward,
Mhm.
or it just lifts up and then suddenly it doesn't look like a tongue tie anymore. So I think we have to be really mindful about how dynamic that structure can seem and can look because of how fascia can change. Um, and how that whole kind of tensegrity dynamic of that stomatic structure can really change. So in terms of like a presentation, I don't think there's like a really, like, I don't know if there is like a real pattern. I might be wrong. That might differ from other people's experience. Um, the obvious things, a shallow latch, inability for the neck to extend, all those sorts of things that might be part of the
Yeah.
picture. But yeah, I don't know. I take every case pretty individually.
That is so interesting because some of the patients we get at our practice are from lactation consultants who actually they're in that sort of gray zone of there's oral functional restrictions, but it's not like it might be an ATLEF 9 or a 10 or something like that, where it's in that kind of
Yep.
gray area. And one of our referrers described it as there's all this tension, but they don't know if there's like the way she described it was she doesn't know if it's like a block of ice with a metal pole in it or not. And so she wanted to
Mm,
see if we could melt the ice and see if there was a real restriction in there or not. And it
exactly.
has been very interesting uh, learning to understand how wide that grey area can be, because I think you're right. There's quite strong opinions on both sides. Some people are like very, very conservative about what things should be snipped, and other people are the other way and say it's an actual like it's a congenital defect and manual therapy can't change it. And I think I think you're absolutely right in that the more you deep dive in it, the more you realize that each case has its own complexities, and like so many things, the more you get into it, the more grey there is between those black and white positions.
Yeah.
Um,
There's so many
really
factors
interesting.
in feeding. Yeah, there's so many factors in feeding as well, because you can see a baby who has a really obvious tongue tie, but there's no functional reason that you would identify it as a tongue tie. Like they're feeding properly, the latch is fine, they're settled, they're happy. So there's a whole kind of discussion around, why do we release a tongue tie for craniofacial development? Do we release it so that they have the best craniofacial potential in their growth, even if they're not having breastfeeding issues? So that's always a really big discussion with the parents, and it really depends on where the parents are at with their thinking. And it's always a really big decision, because it's not really like you can, well, rather you can, but you would rather not kind of wait until they're age 1, or even at 6 months and they're having feeding difficulties with solids, because they're unable to do a proper swallow because they're restricted in the mid tongue, things like that. So sometimes like the presentation might be that the baby had a really great birth. There's not really much of a birth strain going on. They're doing really well with bonding with the mum. They're got really great supply. So feeding looks good, but there's a tongue tie there. So, you know, what do we do about that? And there's not enough
Mm,
long-term studies to really, well, there's enough in the research to say that a tongue tie can inhibit craniofacial development, but yeah, it's a really difficult one. But then also there's presentations where babies don't have a tongue tie, but they're having a terrible time feeding, and they're having a terrible time settling, and they're in so much pain, and they're just all not doing well. And every other practitioner is like, well, it must be a tongue tie. And it's like, it's not a tongue tie. It just needs a good osteopath. Or other things might need to be addressed. Who knows? But yeah, so I find that I think if you're looking at a pattern, a set of presenting complaints and then saying, well, that's a tongue tie, I think then you're wanting to kind of collect more anecdotal data and look at more tongues and start to get really aware of what tongue ties really are and how they can be different for different babies as well. That
mm.
makes sense. Yeah.
So if a baby presented to you where the tongue wasn't sitting on the palate, you'd provide them with osteopathic care for a treatment or two and then do a tongue tie assessment rather than doing one in the first appointment? Yeah, okay.
I always check in the first appointment anyway, just to get a look at what's going on. They might have like a really obvious anterior restriction, and that's, obvious. But you've also got to prepare that baby to have a frenectomy anyway. So if that baby's body and system and cranial system isn't ready to go through a frenectomy, it doesn't matter how obvious that tongue tie is, you have to prepare that baby's system to go through that trauma, essentially. But yes, I will always do intraoral assessment and just collect that data and see where that's at. But if it is just simply that baby's tongue is not at the roof of the palate, that's not enough data to say that there's a tongue tie. Not at all.
Mm-hmm. Interesting.
There's so many other reasons why a baby's tongue might not be on the roof of the palate.
Yeah. Are there any intrauterine patterns that can cause that, do you think?
Well, yeah, like you're gonna see if you're gonna, well, hard to say, really.
The reason I ask is
Um,
I had a baby this week who had a very flexed pattern. They weren't a breech presentation, but I think they just had a really flexed position in utero. And they felt
mm,
a lot like a lot of the tongue tie babies I see, very tight through their jaw and hyoid and anterior fascial line, but no tongue tie. But yes, some oral restriction and feeding issues.
mm.
And yeah, it was possibly one of those situations you're talking about where those fascial connections were just super tight without there actually being like a tie per se.
Yeah. Yeah. And
Hmm.
though, like, if they're just like bunched up under the ribs their whole time and they're not doing all the movement and the motion, and that's when you also start to work with pregnant women. Like, how well is the pregnant woman's diaphragm working? How well are their ribs working? Because that pump with the diaphragm, that's what's kind of sending the motion in a way of the baby needing to turn and move in utero as well. So all that movement pattern in utero has an effect on their growth. But at the same time, the birth process is really important as well. That big stretch up and that movement through their neck and those the reflexes that go on coming out of the birth canal. If they haven't moved through that, and they haven't come out with a big first breath and they're not lifting up their tongue and screaming, like what's all that sticky fascia doing? Like there's a whole big physiological change that happens through our breath and through our cells and through our blood. I haven't seen any research on it, but I'm really curious on how fascia changes at that moment and how much we stretch up through here and the tongue lifts up. That's got to do something to that whole anterior fascia. But you get those babies that haven't gone through that and they're like this, and they can't extend their neck and they can't bring their chin and jaw forward, and their fascia is just like, because their breath hasn't gone through it yet. So opening up through that breath and opening up through that chain, and increasing that extension and bringing them out of that flexion, is going to do a lot for them to get their neck extended, their jaw forward, their tongue sticking out and their tongue up. It's all part of that long tube.
Super cool. So super cool. Can you tell me a bit more about the guided frenectomies that you do?
So the guided frenectomies I do are only on kids who can stay in a chair under a local anesthetic. So older kids, we've
Okay.
done 4-year-olds and 5-year-olds, but they have to be pretty like good kids. And mostly I do them on adults. Um, so it's a long thing. So it's kind of being part of a team consisting of myself, a myofunctional therapist, and the dentist to diagnose the tongue tie in the first place. Um, then you've got to really consider what that person's presenting complaint is, because pardon me. Obviously, after a lifetime of having a tongue tie, there's going to be a lot of compensatory patterns, postural patterns, breathing patterns, tensegrity, fascial patterns, all those sorts of things. But also, we got to determine, is that person's presenting complaint due to them having a tongue tie? So the dentist needs an appropriate diagnosis to be able to release the tongue tie in the first place. And that diagnosis might be something like TMD or speech impairment. There's a lot of discussion around whether you would do a frenectomy for sleep disordered breathing, but really we're looking at dysfunctional tongue oral function. And then we get them prepped for a frenectomy. So they do a lot of myofunctional prep to get their tongue functional, because there's no point in releasing a tongue and then it just like not knowing what to do. So you need to get the function set up. And then I work with them osteopathically. I see a lot of breathing dysfunctional breathing patterns with people who have a tongue tie. So I like to get their breathing pretty stable and their nervous system pretty stable. And then I like to just treat as much as I can treat. And then that means that what's kind of remaining is only the tongue ties input. So I like to treat everything. Just again, it's just osteopathic, can be fascial, can be jaw, can be cranial strains. Pardon me. And then we do the actual frenectomy. So the dentist that I work with uses a carbon dioxide laser. And it's just a laser that pretty much like melts the tissue. And I sit there and I hold the cranial base and I direct kind of, she kind of feels a little bit around and I sort of say, yes, that's relevant. No, that's fine. And we just release what's needed. Just might need to get a glass of water.
Sure.
Sorry.
Okay, we're back. So we were just talking
Yeah.
about breathing dysfunction, and one of the questions I'm really curious about is what breathing issues you see in children and adults that have tongue ties. Can you tell us a bit about what you find?
I think the first and most obvious one is mouth breathing. And so if we're seeing it in kids, if they've got a tongue tie, and that's meaning that their tongue is being held to the floor of their mouth and it's not kind of resting up on the palate, that force of the tongue kind of means that the mouth might drop open and they start mouth breathing. That can lead to upper airway obstruction. So they might end up with enlarged tonsils or adenoids or something like that. And sleep disordered breathing sort of goes on from that. So the really obvious sort of picture that I see in kids is that they're going to have an open mouth posture, sleep disordered breathing. They might have recurrent upper airway infections, like throat. They might, and more I'm seeing kids with neurodivergent things, so ADHD, autistic spectrum sort of stuff, because of the sleep disordered breathing and the mouth breathing issues. So, and then also from that, we're seeing, you know, really kind of things that kind of look like and may seem like retained primitive reflexes, hypermobility, and all of that. So pretty much that's the real obvious picture in kids. In adults, it kind of compensates and it creates all different patterns in adults, and it really depends on their background. But again, we're seeing sleep disordered breathing, maybe an altered kind of craniofacial development. So they might have malocclusion, a high narrow palate, And then that might kind of show up as chronic migraines. It might look like TMD. It might look like chronic neck pain. But a lot of time that might also manifest in more psycho-emotional sort of stuff as well. So anxiety, panic attacks, and that may lead on to something that looks more like a hyperventilation sort of syndrome pattern as well. So it just sort of depends on which direction it's going to take in adults.
It's a pretty grim picture, isn't it? Like it can
Yeah.
affect people so significantly through their life. It's yeah,
Yeah. It
um,
really
yeah,
profound. And I think if you're when you're looking more into the sleep disordered breathing and how important sleep is for a developing brain, and then for a continued brain function, and then for your emotional state and for your nervous system, it's the number one thing. You want your breathing to be good, so that you can get restorative sleep. It is really disheartening seeing parents with kids who are just struggling, or adults who have just struggled their whole life with something and nobody's really identified the main cause that's kind of perpetuated these patterns. It's I really feel for those patients.
yeah. It's one of the best bits about treating babies, isn't it? Thinking about that trajectory that you can send them off
Yes.
onto, hopefully, a better
Exactly.
trajectory.
Yes.
Um, what do you do for babies that have an open mouth posture? What sort of things would you address?
Same things that we probably talked about before. So that anterior fascial chain, what the cranial
Hmm.
base is doing,
Hmm.
um, the tongue, oral function, do they have a tongue tie? Um, they're kind of like the main things. But sometimes it might just be congestion, and you might just want to work on the fluid dynamics. You might need to work on the face itself. You also might need to work with an IBLC and work with breastfeeding dynamics, because breastfeeding in itself is going to clear the nose and bring the jaw forward. So breastfeeding in itself is a form of therapy for mouth breathing babies. So making sure that breastfeeding is optimal. But yeah, it's just osteopathic, like whatever you treat, what you find. Yeah, and then you can do the little exercises for the babies as well, like bringing their jaw forward, holding their mouth shut,
Hmm. Hmm.
some of the guppy stretch, um, some of the oral kind of exercises that they give, that sort of stuff as well. But I focused a lot more on treatment.
Gotcha.
Sorry, there's a mozzie flying around.
No worries. So what percentage of your practice at the moment is babies and infants?
I would say probably 50-50. I probably
Oh yeah.
see 50% like little babies, um, and then 50% either kids and adults.
Okay. Okay. And is it a lot of
But it kind of changes.
general? Yeah. Okay.
Yeah.
Um,
Sorry, what were you saying?
and I was just going to ask you sort of like your like most favorite patients. Like what sort of things do you love the most?
My favorite patients are definitely little babies, like, you know, from newborn, like up until 4 months. They're my favorite. My favorite adult patients are the ones that everything just sort of comes together for them, in people who have like TMD, breathing dysfunction, sleep disordered breathing, emotional stuff. I feel like I can kind of bring it all together for them and really explain how this all came about, and really kind of give them um, reframe their experience on what they believe is going on in their body, and give them a little bit of like, this is what we can do to address that. So, um, and probably women, because I really love women's health, and I really think that sleep and breathing and TMD is a women's health issue. I think there's something like TMD, I think 70% of TMD sufferers are women. And I also think that sleep disordered breathing and breathing dysfunctions are very misread in women. And I think they're either told that they have a hormone issue, and especially with women who are kind of like 40 years onwards, it's like, oh, you just have menopause. But I truly believe that if we address sleep and breathing in so many women who have endometriosis, chronic pain, chronic pelvic pain, even if we address a lot of that sleep disordered breathing, then addressing that inflammation, addressing pain, I think that's like a major part. And it's written in the research as well. It's just not really gone very deep into it. It's just shown in the research that most women with chronic pelvic pain have sleeping issues. And that's kind of as far as it goes into the research. So that's probably my favorite. So if like a woman walks in and she's got, I had this pain here, and I've also got pelvic floor issues, and I've also got ADD, and yeah, I sleep well, but I never wake up refreshed. That's kind of the picture that I mainly work with.
Because you can like blow their mind and change their life.
Well, I think as well, it's just about that path thing, the trajectory. It's like they've been on so many different paths already, and they've been working with like their ADD and all that sort of stuff. And it all works just a little bit. But if we can just get them on the right path, then obviously as a practitioner, that feels rewarding to kind of be like, especially for people who are like just been looking for an answer for so long, and they're just not told anything really, and they're just told little bits here and there, and they're just trying to put it together for themselves. Or they're given a certain diagnosis and like that's it. There's no, treatment to that. It's just like, oh, well, you got that, off you go. And as with sleep stuff as well, women aren't necessarily going to get an appropriate diagnosis because women aren't necessarily going to have a high sleep apnea index. So often when women are given a sleep study, they're told that there's nothing wrong or that it's positional and just don't sleep on your back, where actually they've got a very high arousal with their brain. And so women just aren't being diagnosed properly.
Wow. Because I'd certainly, I was aware that there was a link between, say, pelvic floor and endometriosis issues and jaw pain, but I just kind of assumed that all that local pelvic inflammation was causing strain patterns through the fascia up to the jaw. But what you're saying is that that could be the primary and that could be the secondary. Okay,
Could
that's
be. I'd love to do
so
research on
interesting.
it. I'd love to,
Yeah.
yeah, if I was more academic and less neurodivergent myself and able just to like stick to something, that would be like the research that I'd really, really love to do. And even just to the amount of people with endometriosis that I've identified a tongue tie, sleep disordered breathing, and jaw issues in, you know, pelvic pain doesn't really come on until you get your period, but you start breathing and sleeping straight away. And those things developed from right before that. So if you start to think of things even just mechanically, how the diaphragm's going to work, how the fluid dynamics are going to work, but then you start thinking of things biochemically, what sort of things happen in deep sleep, what hormones regulation happens in deep sleep. And if you're not getting that, then you're not getting hormone regulation. You're not getting anti-inflammatory properties from your deep sleep. So yeah, I think it's a huge, huge factor in chronic pelvic pain for women. And I would love to see research done on that.
Wow, that is so osteopathic. It's like the body is a unit. Like, wow.
Imagine, imagine it's actually connected.
Oh, this is why I
Yeah.
love doing this podcast because the osteopathic philosophy and concepts are just so profoundly fantastic, aren't they? And
Yeah.
the way that we look at the body and think about these things is there's so much we can do to help in so many interesting ways. And I just feel like there's people like you that just have thought so deeply about all this stuff. It's just such a joy to meet you and
Uh,
to listen to you talk. It's just so fantastic. Really, it is.
oh, thank you. That's
Um,
sweet.
my last question for you was if you've encountered any really memorable cases. You did talk about one already with the
Uh,
woman that comes in with the plethora of symptoms. With that,
yeah.
is there anyone you've treated lately that's come to mind that you could talk us through a case?
I was trying to think of this, but I think people, I might be a different osteopath than most because of this, but the memorable patients are memorable just because of who they are. They're not really memorable because of their cases. Like I've done so many of the frenectomies now, and they're always really interesting and surprising as well. There's like some patients that I've seen that it's just been, it's just really opened up so much and changed their perspective on things just simply because now they can move their tongue now. Um, do you know, like really, there's probably one baby that really sticks in my mind, and it's probably more an emotional one. And it was a direction that I actually tried to go in, but there just wasn't many cases like came, that came up. But I saw a baby that a foster family had horrendous way and had been removed from the birth mother. And feeling that little body was a really different experience to what you would normally feel. And on top of like all the other stuff that I'm really interested in, I'm actually very, very interested in how trauma and emotions really shape and what we feel like, what our bodies really feel like. And feeling that little baby's body was something that I will never forget. Like that was so much more than just, oh, there's some fascial restriction here or the cranial base is, compressed or whatever. And I think that's what osteopaths, our way of palpating goes so beyond those very simple musculoskeletal things that we can feel very well, but to feel into the depths of emotion and pre-verbal emotion that really shaped, I think, the way that I use my palpation. But that is probably one of my most memorable
Mm,
uh, cases. But in terms of memorable patient, I just have,
mm,
I've had some really great, interesting patients and really lovely
yeah,
patients that end up, I had a patient that like painted me a painting, and
yeah.
that was really beautiful, and she was really lovely, and patients that you just sort of like really vibe with,
Hmm.
and you just
Hmm.
suddenly like, oh, we friends now. So just paint like, you're in a
Mm,
room all day with a lot of different people. It's just
mm,
really great when someone comes in that you actually want to hang out with.
hmm.
So,
Hmm.
and that you want to spend time with. So it's just nice when you get nice patients or cool patients. That's
Yeah.
probably just, just thinking of some of my patients. I'm like, yeah, they were just like interesting, or they've done interesting things in their life. But in terms of like a case, I don't think I get that hung up on cases. I'm not really one into like, even with the presentations I do, I'm not really into like doing a case study. Like, here's this person, here are the outcomes. And I find that stuff really boring. I'm more interested in people, who they are.
Mm, super interesting.
Mm.
Um, Back to that foster baby.
Mm.
Um, this might be a very difficult question to answer, but how would you describe that baby's system? Like, did it vibrate, or was it heavy, or was it dense, or was it like,
It
what
was
did you
like
feel?
being in a dark, lonely room.
Yeah.
Yeah,
Okay.
it wasn't
Like,
vibrating. It was beyond being shut down.
yeah, okay.
It was like sitting in the most quiet, lonely space that you can think of. Yeah,
Okay.
really.
Hmm.
But we gradually brought him out of that. And what was really interesting about that case is that, you kind of do feel those babies that are just like
Yeah.
buzzing because they've either had a traumatic birth or maybe
Mm.
they got a lot of anxiety in their family or whatever might be happening there, or they're not bonding well with mum. And they're
Hmm.
that kind of sympathetic. He was shut down. And as I
That
worked with
fuzzy.
him, he
Yep.
kind of came up into that. And then he
Okay.
started getting really unsettled because a shutdown baby is a quiet baby, is a baby that's not doing much. And you don't want them to be there. Like that's emotionally, that's not where you want babies to be for
Yep.
development. But as I worked with him, he did gradually come out of that and into a state of like just wired.
What the
And
hell just happened to me kind of a thing.
yeah, and
Yeah.
he was also born addicted to substance because of um his biological mother.
Hmm.
And so there was also a lot of that in his body as well. And that was very buzzed. Um, and then, yeah, and as we unwound, he just got more and more compressed. So it's almost like we had, I had to work with him about 4 or 5 sessions just to get him to where, like, if another baby came in on that first session, I would say, wow, this is a really wound up, compressed baby. Like, this isn't good. But because
Hmm.
that was like bringing him up out of that state into actually like being here in his body, and his body
Mm.
wasn't a happy place to be in
Mm.
because it was just so compressed and buzzed. So then we had to keep unwinding from there. So it was a lot of work, a lot of work. And at first it wasn't really doing much. It was literally just sitting with it, just sitting with
Yep.
in that space and being like a presence in that lonely space with him.
Yep. Yep.
Yeah.
Just hanging out with him.
Yeah, hanging out like I'm just in this room with you. That's it.
Yeah.
Yeah.
Oh, that's really cool.
Yeah, it's a tearjerker. Yeah, I quite often get teary with that one too. And I try to get because I found that so rewarding, and because often foster carers don't have, much financial help.
Yep.
So I did kind of offer service as, to anyone with a foster baby. I really wanted to continue that work, but it just didn't. I think there's so much red tape around that sort of stuff. And
Yeah.
I think in
Oh.
that area, the help that they do need and the support they do need, they don't really see osteopathy in that. But I did try to kind of through that foster parent, but
Mm.
she was looking after like 6 or 7 other kids. So even just bringing
Wow.
um,
Yeah.
somebody was like a big deal. But I tried to kind of reach out and be like, if any other families want to come to me, but it just didn't
Mm.
really get out there. So, but
Yeah.
if any other osteopath is in that space, I
Yeah.
yeah, that would be a really beautiful, difficult, but beautiful space to work in.
Definitely. We've had a
You're
policy for
so
years at my
sweet. That's so
practice that we will treat foster kids for free. And we've had a similar situation. We've had a few families come through and
yeah.
provided care. So I've seen a few over the years, but same thing. I think there's a lot of red tape to bringing foster children into medical appointments. There has to be a process followed. And sometimes you're right, like the foster families have limited access to transport or time and things like that. And they're so overwhelmed with OT appointments and psychology and a huge pile of other things that these kids often have to go through. But it's such important work, isn't it? So it's cool to
Yep.
hear that you're
It
you're
is.
up in Brisbane and
Yeah.
that's an option.
And it's
Definitely
amazing to hear that
something
that's a
good to do.
policy in your country. Yeah, that's awesome that you're offering
Yeah.
that out there. I honestly
Oh,
think
yeah.
one space that all osteopathic clinics should be offering is to the foster space.
Mm.
They need all the support they can get.
Yeah, we should do something more about that. For a long time, we've really wanted to set up like a free clinic because that's something that's worked in various places around the world, hasn't it? And
Yeah.
it's certainly a model that's been trialed here and there uh, really successfully. Um,
Yep.
it's always a bit of a challenge in private practice, isn't it, to work out how to do it? But
Yeah.
for us, offering foster families free treatments that just come and just work, come and see us in our practice and that sort of thing, seemed to be just
Yeah.
like the simplest way to start. Um,
Yes.
but down the track, we've had a few conversations about maybe having a space at a local match service or something like that, just a day a week or even a day a month, and just providing free care to low income families. It's one of
Yeah.
the crappest things really about our profession, I think, is that we're not really able to like yeah, low income families don't really have access to us unless we have some sort of system like what you've set up with foster families. And yeah, certainly it would be nice if there was
Yeah.
other more
Yeah.
options
And
for
I
them.
think it's just right place, right time. Like the other patient I was thinking of that I was telling you about who
Mm.
painted me the picture, she was an amazing woman. And she works for part of the government that works with teenage mothers and
Oh yeah.
mothers who are houseless. And I said to her, I'm like, honestly, if any of them need help with their babies, help with breastfeeding. But the really interesting thing is that most of them don't have problems with breastfeeding,
Oh,
which
okay.
is, I found really interesting.
What's your
I have
theory?
another friend who, I think I don't think that they've had access to the overwhelming information, and I don't think that there's as much overthinking and fear of
Okay.
breastfeeding. Um, she said that there definitely is some that just prefer not to breastfeed. So there's as well, I guess, in their sort of situation, it might be that they're just, it's not part of what they're used to. They might not
Yep.
have family kind of support to be able to think about doing that. So they just go straight to
Hmm.
formula. And so coming to see me and me kind of helping them do that just might not be a part of their agenda. Um, but yeah, I think that, yeah, maybe it's just that they just get on with it. Don't know. It's the
Yeah.
same as I offered to help a friend of mine works at the council in Kakadu and works out on country. Um, I didn't offer to help. I just was curious. I was like, how do they go birthing and breastfeeding? She's like, it's no problem. Like breastfeeding issues is just white women issues, like white person issues. Like really, Aboriginal women also don't, because you think of how wide their palates are. Um, and how much our skulls have from kind of like English Caucasian background, how much our skulls are just not doing very well. But yeah, they're doing fine with breastfeeding out on country.
Gotcha.
Mm.
Generations of the Western sort of grain diet and things like that.
Yeah.
Yeah. Many years ago, I worked at a women's refuge. Just once a month, I'd go in and just take my portable table. And a lot of the women that I treated there, you're right, there weren't too many breastfeeding issues. If they were like a lot of the women were younger. So, for example, where I live in Canberra, a lot of the women we see are probably in their sort of mid to late 30s.
Yeah.
And a lot of the women that I was seeing back then were early 20s, late teens even. So I
Yep.
wonder if that's a little bit to do with it as well. Like you said, sort of less expectation to go back to work and, be super mum and all those sorts of things, and just a little bit less pressure on them overall in some ways, not in others.
Yeah. Yeah, I
Yeah,
think so.
but that's very interesting. I
Yeah.
heard something the
That's
other day about,
amazing work that you
oh, it was a while ago now. But again, something that there's obviously there's opportunities here in Canberra that we could be taking advantage of. It's just been it's one of those things, that you kind of get carried away with all this stuff, and then it's so nice talking to you to be reminded about, how important that stuff is too, really. Yeah,
definitely.
yeah. And how much they teach you as well, these people that you really maybe would never see an osteopath otherwise. Because in our practice, the vast majority of the babies that come and see us are, you know, two parent families, middle class. You know, they've they've got all it's a very specific demographic, 99.9% of the time,
Mm.
and there's such a range of, like, yeah, being out on country and treating babies on country would be such a different experience too, wouldn't it? And you'd learn so much and have such different experiences of under your hands. Hmm.
Yeah, and I think on country they probably have their own means of healing, and but if we were invited into that space and invited to share in that wisdom, that would be incredible. But also, you're right, you do just see a pretty small demographic of, middle class two parent kind of with their children that you don't really see too many outside of that. So as much as we can kind of like find those spaces to help in, and that's probably why osteopaths should be in hospitals and kind of be offering our services in other spaces.
Agreed. And
Mm.
also NDIS, like at our practice, we've just really started seeing a few more NDIS patients and co-treating with some local OT and physio um, clinics that we inter-refer with. And
Yep.
that's also an area I think that we could be so useful in, with these babies that have various sort of diagnoses and NDIS support required. There's just so much scope, really, for
Yeah.
who we can help. Yeah, so interesting. So
Yeah.
what's
And
the
it's
plan for you
where
for? Oh yeah, go.
I think
Yep,
our skills really shine. No, sorry. I think there's a little bit of a delay, but I'm good.
go for it. What were you going to say? Sorry to interrupt.
No, I was just saying that, those spaces, especially with within the NDIS, I think that that's where our osteopathic specific skills can really shine, can really help out those kids, especially within kind of what their cranial work is doing. I think that's an area that is really needed. I think there is quite a few osteopaths working in that area, hopefully.
Yes, definitely. I think it's starting to get better. And I actually saw the other day that we've probably got a bit more support as far as line items and things like that coming through. Uh,
Mhm.
for anyone watching this outside of Australia, NDIS is our National Disability Insurance Scheme, which covers people with a disability within Australia for healthcare. So sometimes osteos can look after patients through that scheme here. Um, so what's what's the plan for you for the rest of the year? I saw you're obviously you're presenting at ASTOP, but you're also presenting at some other conferences this year. What's happening for you for the rest of 2025?
It's going to be an interesting year for me. I actually just closed my clinic. So I am still kind of working and I still have colleagues working for me, but there's no kind of like more pathways clinic. So I'm hoping to take more pathways online and have a bit of an integrative learning hub, both for
Hmm.
practitioners and patients. So getting a few more courses written for patients in the breathing, sleep, kind of way. I've already done one. And then I'm writing a few in-person courses. And that there's just so many things I'm doing in the background. I don't know when these things are actually going to like launch, but hopefully by the end of 2025. I'm hopefully going to get one of the courses on like happening by mid-year. And that will be like the osteopathic guided frenectomy. And I would really like to get a case study written and hope published one day. So heaps of stuff happening in the background when I don't know when anybody will see that work completed, but that's my intention.
Amazing. Well, please let us know on Osteo Kids when those things are up and running. Um, I think that'll be fabulous, fabulous for us to all know about. And yeah, it's been such an enjoyable chat with you, Natalie. Thank you so much for your time today. Um, yeah, it's been such a pleasure.
Oh, it's been such a pleasure. Really nice talking to you as well. Yeah.
I'll see you at ASTOT.
See you there.
See you later.